Welcome back to The Short Coat. Coming to you from the amazing and intense world of med school at the University of Iowa Carver College of Medicine. I'm Dave Etler, and I'm joined here in the SCP studio by my lively co-hosts, including PA2 Chloe Kepros.
Hey, everyone.
M2 Nick Lembezeder is here. M2 Sarah Nichols has joined us.
Hi.
And M1 Jonah Albrecht.
What's up, party people?
So we're going to keep talking about death and dying, but you'll want to go back and watch part one of our discussion if you haven't. This time, Nick, I understand you did some work with hospice and palliative care prior to med school.
I sure did.
Yeah, tell us about that.
So I did my master's in public health here at the University of Iowa, and one of the really cool opportunities that all MPH students get here at Iowa is to do a practicum project with a local community organization. And so I partnered with Iowa City Hospice, which is one of the very few actually nonprofit hospice organizations here in southeastern Iowa. And my first project for the practicum was looking at accessibility of hospice. Mm-hmm. Who's using it, who's not using it, and what barriers might be existing that are preventing certain people from accessing it. So I was specifically looking at Hispanic people here in southeast Iowa and their utilization rates. Mm-hmm. Now that grew into another project, which I was able to do this past summer between my M1 and M2 years. And this was more clinical research, which was really exciting. And so we were looking at patients who are approaching the end of their life. In order to be on hospice, you need to have a terminal diagnosis with a prognosis of at least 6 months, or at most 6 months. But it's most often not just that terminal diagnosis, right? You may have some form of cancer or whatever it is, but you also have osteoarthritis. You also have all these other things that you kind of accumulate as you live. And so those conditions don't go away. Mm. And what our research project was looking at is how can we use a non-pharmacological therapy? How can we use something that's not another opioid to treat patients' pain at the end of life that may or may not be related to their terminal diagnosis? Mm.
So what kinds of things did you learn?
I learned quite a bit, actually. It was a really good review of a lot of the things that we learned in our first year of medical school, just physiological-wise, but medication review was really interesting. But I think I learned the most about healthcare management, how a small hospice agency here in southeast Iowa functions, what the roles of the nurses are, the medical director, the fellows who are helping train in palliative care. I think I learned the most how clinicians of all specialties and levels interact with patients who have a terminal diagnosis and kind of the inner workings of the organization. That's where I think, learned the most.
Is palliative care something you're interested long term?
It's something I'm very interested in. It's something that got me into medicine, honestly.
Yeah.
If you listen to our first part, short coats, you'll hear that we talked about a good death, what a good death is. And I was a classical studies major in undergrad, and so I took a lot of Latin and Greek languages and things. And whenever I think of good death, I think of the euthanos, the euthanasia, the good death. If you break that word down, that's what it means.
Oh, I did not know that.
Pretty interesting, right?
Yeah, something new every day, Dave.
It's also
medical
see?
School.
Yeah. It's also where Thanos, the supervillain of the Marvel universe, gets his name.
Also didn't know
Thanos, death.
Okay.
And there's no new idea under the sun, folks.
Yeah.
If you want
a giant purple space monster is equivalent to the Greek and Latin languages.
Okay, but this is actually kind of crazy because if you really want to get into the weeds on this, Thanos is based off of this concept that's been around for a long time called like the Malthusian theorem, which is like this age-old theory that food will never reach the population will always outpace the demand for food.
Okay.
Mm-hmm.
And so then the idea is that Marvel got this idea and took Thanos' death and just solved the Malthusian dilemma. He said, let's kill half the population, then we'll have enough food. Anyway, where was I? I think I am interested in palliative care, absolutely. The idea of the dying process, this is going back to my first point, is part of really what got me interested in medicine, because at its core, I think that it's tied for the most human experience you can ever experience
Yeah.
between birth and death. I think those are the two things that pretty much every human, it's obligatory that you do both of those things. And so, yeah, I think I really want at least conversations with patients about their end-of-life plans. I really want that to be a part of my practice. I know I really want to do primary care, and I'm not quite sure what shape that's going to take yet, but yes, I'm very interested in it.
I think whatever type of physician or physician assistant people end up becoming, right, you need to be good at this. This is something you have to be good at. I think there are very few skills that like everyone should be able to do. I think this is one of them because, like you were saying, it's so important.
It's not necessarily true, though.
Yeah.
Okay.
Like, you think that you have to be good at it, and I agree with you. People are not good at it.
Oh, yeah.
Yeah,
no.
yeah.
It's like, I'd love to see where she's going to take this.
No, I'm just saying, I'm like, the reality of the
No,
situation.
100%.
I also
100%.
think we would all love to think that everyone believes that. Like, everyone thinks we should be good at this. And I think that's unfortunately not true either. Like, we get these very limited, like, palliative care lectures, and people are kind of like, ugh, why do we have to do this? This is silly. I'm not going to do that. And it's like, you will engage with someone no matter where you're at.
I think that's a big part of the learning process in becoming a PA or physician is thinking to yourself, when am I ever going to need to know this? And then eventually you get to eat crow a little bit and realize like, the Krebs cycle. That is something I needed to know in this one small moment.
Citrate did come up in our last test just
Yeah.
today.
Like, come on, I've already unmemorized it, man.
It's okay. You don't need to know the Krebs cycle for it. just to like giving it to prevent stones. Anyways.
That sounds like a future me problem.
Yeah, exactly. Yeah. But I think like, because also you mentioned, Jonah, like you said, like I'm not an expert. I would say it sounds like Nick is much more of an expert than I am in terms of palliative care. I had the chance to work because I worked in medical oncology as a care tech for preclinical experience. And so I had hospice patients, and like my third day working as a care tech was the first time I had someone pass away and was like cleaning their body and preparing it for their family to say goodbye. And like we'll never forget the husband coming back, and I had kind of put her hands like over the blanket so that he could hold her hand if he wanted to and her family could. And I will never forget him being like, we have to cover her hands, they're going to get cold. And it's this recognition of like that, him not recognizing that that person's not there anymore. And then also like over time engaging a lot with that process, like me being able to have this very indescribable feeling of knowing that that person's not there anymore, and that that is a body but no longer a person. And it's a very interesting thing that like I can't explain with science. And I think we've talked a lot about this idea of like death is something that we don't yet maybe have scientific knowledge on, but it's quite fascinating too, because like there's a lot of things that we didn't know how to explain with science for a long time. And I think sometimes like the idea that something happens after death, some people say, well, scientifically there's no proof, so that can't be true. But it's quite fascinating because like maybe we just don't have the tools to be able to measure that.
Yeah, maybe we will never have the tools to measure that. I think that there are some things in science that are, and I'm taking this phrase from somebody else, that are sort of beyond the knowable. And you can look at that as you know, just, you know, a fact that we as humans inhabit bodies that are made of physical stuff and that obey the laws of the physical universe, but that there are more things out there. Anyway, I don't know. Like I sometimes think about that in terms of death. Like we don't know what's out there. We don't, you know, we can feel certain about it, but the truth is that there's so much more to learn. We might never know, but it's fun to find out.
Like definitely maybe more things than what's like measurable. Yeah, because I think science is one construct of how you can know things that's very much based in what's measurable and replicable, and there's a lot of stuff that doesn't fall under that realm. And I think also just like working with hospice patients, I'm sure that Sarah, you might have experienced this too, but there's so many times where someone will be telling you like their family members in the room, they're able to describe them, like there's a lot of that, and you really start to see these similarities in as someone approaches maybe in that process of death, the times at which they start to describe those things and maybe be aware of like people in the room. And it's very fascinating because it's like when you watch the process over and over, which I think a lot of like palliative care specialists and nurses and things, they see that process, you start to recognize that there's these similarities that like you can track. And there is like very interesting, there's a doctor who clinically died. She was like kayaking in Chile, I think, and her kayak flipped and got stuck. And she was very much clinically dead and brought back after like 30 minutes or something. They think at least of her heart being gone. Like it was like, just like, also just like completely improbable in terms of like medicine and what we know, that she would be alive and that she would not have major brain damage because she's completely like fine. And like she wrote a book, I believe, called Surviving Death, and they made like a Netflix kind of limited series in which they go into like near death experiences like hers. They go into like mediums. It's very fascinating because she's like, I'm a doctor. Like I have this idea of like what death is, and I did before. And then I had this whole experience, and she was like told by people on the other side that her son would pass away, and it ended up kind of happening along the, it was like very fascinating how it was
how
like,
do I explain this
yes,
as a person
yeah.
of science? How do I explain
right
this?
And very interesting to have someone who I think like us is very rooted in that scientific explanation of things, but yet has had something to happen to her that she's like, I can't explain that. And I forever am changed by that, and I think her perspective is very changed. So
I think what we're talking about is really, really important. And I think it's something that in my life experience, people don't acknowledge or talk about enough, is kind of this, in my understanding of the world, there are these two opposing points of view. There's the one where evidence-based medicine can solve all of our problems and answer all of our questions. And there's the opposing view where it is a fundamentally limited knowledge that cannot, like you're saying, Dave, there are certain things that are unknowable about things that are within the clinical domain of medicine, like death. And I endorse the one that we're kind of talking about, that there are things that science is incapable of explaining or understanding. But I don't think that's true for everyone. And I'm not saying that what I believe is right, but I just think that it's really important that all of us who are entering the field of medicine ask us this question and think about it, because I think so long as we're aware of it, it'll help guide our decisions in the future to be much more wise about what we're doing.
Well, part of the reason I talked about it was because, you said, you put this woman's hands over her blanket, and her husband came in and was like, oh, what if her hands get cold? And I wonder what your response was to this, or if you responded.
Yeah. I mean, it was my third day out there. Like third day of like patient care at all, much less like this very like monumental thing that I'm like witnessing in terms of like what it means to be human.
Yeah.
And I definitely got very teary. And like, honestly, like most times I tell that story, I still get teary. Like, and I'm a sap, so there's that. But also,
it's fine.
Yeah, but I think like that's a good thing too. Like I'm very much like I am very much of the a belief that like it's okay to show emotion with our patients, because I don't need to like strip everything human from myself to be able to be a good provider. If anything, I think being able to be human, yes, sometimes having to rein that in to make sure it's not becoming about me.
Yeah.
But still, I think it makes me a good provider. So.
And I think there's a flip side of it, in that sometimes, especially in situations where other people are still relying on you, you have to be able to flip that switch, right?
Yes.
And this is I think this is the thing I had the hardest time with in the ER, was going from calling a time. I mean, I didn't call it, obviously. I'm not a doc. Jeez. That's why I'm here. But going from that, hey, this cardiac arrest has ended. Like, we are no longer going to continue resuscitation efforts, time of death, blah, 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 moment of silence. Walk out, go into the next room, and they're wondering where everyone's been for the last 30 minutes. Mm-hmm. They are scared. Their emergency is still ongoing. And you're not going to say, well, someone just died in the next room, so maybe you could chill out. Like, that's not how that works, right? Everyone's emergency is important to them, and you need to be able to meet that and recognize that. And I think that encourages us, or at least the incentive is there, for us to not process those moments, right? And I still remember this as like the first time I'd ever experienced one cardiac arrest. I experienced 3 within a 48-hour period, right? First one, out of nowhere, in the ER, got them back. I felt invincible. Second one was being flown in cardiac arrest, which was pretty rare. It's not something that usually happens. And we didn't get him back. And I remember I was like, they had called it. We had taken our moment of silence. I was sullen. Obviously, it was my first time ever experiencing this. And the attending looked at me, and he was like, "Hey, you good?" And I was like, "No."
Yeah, no, are you?
No, I'm not. I don't think you should be either. But the incentive is there, right? And then,
Well, I mean, it sounds like the switch needs to be flipped back and forth very quickly.
it
in that
does, and
environment.
that is distressing for people. And then the
Yeah.
time after that was another loss. And I think this is where we get to, is death knowable? I think it's knowable in how it affects the people that it leaves behind.
Yeah.
Right. And I remember because it's a sound I'll never forget, but it was a family member who was just wailing after finding out that their 21-year-old had just died. And a nurse, and I can't remember her name, but if for whatever reason she's listening, I love you. I will forever remember this. But she grabbed my face, stared me down, and said, "You need to process this. No one here is going to give you time to process this. If you want to, I don't remember what she said exactly, but if you want to stay human, right, you need to take the time to process this. No one is going to do it for you." And I sat there and I took myself into a private room and I cried, like right then and there, right? And I think that's what we have to, there has to be some incentive for us to be able to process those things, for us to be able to avoid burnout, moral injury, moral distress, for us to be able to stay in this profession to reduce the physician and physician assistant suicide rate. For us to get those things down, for us to be able to address those problems, we have to have that type of support, not just from incredible individuals making Herculean efforts for someone who was clearly experiencing that for the first time, but also from the institution for everyone to be able to have that same opportunity. So that way we don't get to the point where it is something that is so normalized for us that we're unable to feel anything when it happens.
Mm-hmm. Yeah, I shadowed a PA in the ICU because I was just like trying to get shadow experience. And I remember it like kind of shaking me because I was like, I don't know if I can go into medicine anymore after this. Because I talked to this PA and he was like, yeah, after COVID, like I can code a 25-year-old woman, like she dies, like I move on with my day as if nothing happened. He's like, I like don't have those feelings in my body anymore. And that like shook me to my core because I was like,
do you think that he felt like this was a good thing?
I think he was just kind of numb. Is what I perceived it to be, at least. And I think that that's the thing, is like there is a protection there, and it's normal that all of us protect ourselves when you're in a situation of something that's very difficult, to be like, I can't process this now. But the question is, yes, the question is whether or not you allow yourself the space or are given the space to be able to do that processing later.
And that's like, remember we were talking about like efficiency of like an eating tube earlier, right? It's the same thing. It is efficient to be able to move on with your day. Mm-hmm. It's efficient to not have to take the time to be able to process that moment. Maybe you don't need to cry. Maybe you just need a moment to remember what this person just left behind, right? It's efficient to not have to do that. The system doesn't want you to do that. The system wants you to be, get your RVUs, become more productive, go see your patients, get your tasks done, do those procedures, right? Make money. That's what they want you to be able. Okay, I feel like I'm getting very...
It's okay.
Anti-establishment on this one. Yeah, no. I am like that, but
we talk about this a lot on the show. There's a tension between the business of medicine and the caregiving end of medicine.
And I think it's very much also a cultural thing, right? Like if one person begins to process these moments, then other people are like, oh, do I have to do that too? That's really hard. Mm-hmm. I don't have time for that. I'm not getting paid enough to do that. I got to think about all the things that are going on in my life outside of this freaking hospital, right? Mm-hmm. I can't also have this weight on me right now, or it might just, it might be too much. But I think that we have to be able to create some type of system or some type of environment, some type of culture where we're able to process these moments.
Well, I know that there are some systems, and this, I can't remember, it might be emergency medicine, where there are efforts being made to, basically get people together in a group who were at a code or whatever, and talk and, help and actually processing.
It's a real effort. So. It's a real effort, but how often does it happen?
I don't know. Yeah.
So I can tell you in my ER, the impetus was there, right? People were like, we should talk about this. And then it just sometimes doesn't happen.
But institutionally,
maybe the surgeons will go do their own debrief, right? Or, the trauma surgeons will go do their own debrief and then just have notes for everyone else, right? I honestly can't think of a time. Not that I was in it for that long, right? Like 9 months is a drop in the bucket of a career.
Could see a lot of death in 9 months in an ER. Though.
Yeah. I mean, there weren't those moments because of the fact that we had so many other things to do, right? Yeah. I don't have time to debrief this. I have 10 EKGs to go, complete right now. There are 40 people in this waiting room, so any of whom could code at any minute in this waiting room. We have 20 plus hallway patients, and we have a third of our ER just waiting on beds upstairs, right, in the inpatient units. There are all these pressures that are telling you to go, go, go. And yes, the debrief aspect is there. I have seen it work. I have seen it work very well. But it's often only in those most traumatic moments, right? Maybe you lose a kid. Maybe you lose a coworker who coded at work, which is something that that's something that happened in my last company. Not with me personally. That was not something I was at, but security guard at a hospital, unfortunately, that we were going to. And it's only in those most traumatic moments that we're able to say, oh, we actually really do have to do this right now. The rest of it's considered mundane. We compare a person who came in cardiac arrest who has, just didn't make it. We consider that like an abdominal pain in that we just need to move on, right? You have to just be able to keep going. Can't let that weigh you down all day. And I should specify that I'm not saying that happens all the time. I'm not saying that's how people are always feeling. There are incredible people. All I'm saying is that there is an incentive there. There is a push. It is more efficient to be able to do those things. And I've definitely gone on about this too long. So Dave, cut some of this out.
No, I think it's so good. I think also like on the individual level, like you're like, I can't save everyone, but I can like damn well do my hardest and do the best that I can do. And if that feels like I have all these other patients who are also in pain, who also I might be able to do something for, there's this feeling of like I'm doing something less than or wrong if I don't just move on.
So moving on quickly can feel therapeutic in some way,
or feel like it's for the better,
right,
for the greater good.
Yeah.
To bring in a
concept. You get very utilitarian very quickly in these moments, right? It very quickly becomes almost like a mass casualty incident where you're like, God, we just got to move, save who we can save, do the most good for the most number of people, do the best we can with the resources we have and the limitations that are imposed upon us. Yeah. So anyways, not to belabor the point, but
it's healthcare in general. It's a giant ethical problem of like, even like with palliative care and like discussing death with patients, or in the ER, like protecting like your own mental health and like the well-being of the team that you're working with, is the best way to fix that is more time. So like more time to debrief, or with a patient, instead of having 15, like a Medicare appointment's normally like 30 minutes to talk to a patient. If you had an hour to talk to that patient and really get into like, what are your values? What do you think about death? You have a chronic illness you're going to have for the next 20 years of your life. Like, what do you want that to look like for you, like in the next 20 years? If you have an hour to do that, you can get a lot more done. You can really get deep into it. You have an extra hour in the ER. You can sit down and debrief. Everyone might be happier, but like you said, then there's more patients piling up. And it's the same thing on like an outpatient perspective of like, you saw that one patient for an hour, maybe 2 hours to really get everything done. And you could have seen 4 patients in an hour and helped more people. Which one is more ethical? To help to maximize one patient's care, or to do 8 patients' care, but like optimally?
It's not an easy question to answer. Yeah.
And like nobody has perfected it.
I mean, it's like a true real life trolley problem. Like we all, like, I think everyone has been in an ethics class and you've had to do the trolley problem. And you're like, this is ridiculous. Like, oh well, it's coming for you at someday.
No, he definitely has.
Calgin's already on it.
Okay, he's already on it. But I think like it's like everyone's had that experience where you're like, this isn't applicable. I'm never gonna have to deal with this in real life. And it's like, but I think in medicine you are faced with that, especially in urgent and emergent settings. But even in general, I think even if you're in primary care practice, you're considering this person who's in a ton of pain over here. Like if I spend more time with this patient whose problem to me seems less urgent, then I'm not able to spend that time with this patient. But that person, like that's their whole life. And so it's just such a difficult thing. But I think sometimes like in some of my small groups here, I notice that people are just very like, I don't know, I feel like I'm surrounded by a lot of like kind of utilitarian mindset and just kind of like almost this defeatism of like, we can't do better because we just can't. And I'm like, I think just because we can't fix the whole system doesn't mean that we can't be like striving to do better or
At
having
least
the
thinking
discussion.
about it, at
yeah,
least,
yeah. And I think like even it's interesting, like one of our friends, Bryn, is very interested in pediatrics and I think has volunteered at the very least, if not worked in the pediatrics hospital here at the Stead. And she talked about how at least on one floor, it might be like peds oncology, that when a patient dies that they will like have like a candle that I think is not real, but like a candle, like fake candle lit in the room, and the room is left empty for like a 24-hour period or something, so that anyone involved in their care is able to go and sit in the room and take time to like process that. And I think that's awesome. And immediately my mind goes to like, oh my gosh, are there like other sick kids who are like not able to get that bed? And it's crazy, I think, how difficult that is, and also how trained we are to be thinking about it. But it's just like a finite amount of resources, and it makes it very, very hard.
What do you guys have to do after this? Should we continue? If we go over?
I can go.
I don't mind going over.
My next commitment is at 2 p.m. So
Sweet.
It's break now.
Yeah.
It is
I kind of thought maybe,
I'm
but
done.
I don't know.
We have a
Sometimes-
career advising fair, but do I really look like a future neurosurgeon?
I didn't
think
go to
so.
a single thing. My M1 year, the Thanksgiving break career fair, I
Yeah.
looked at the list. I saw that it was all surgical. And I said, I've been in an OR. I'm not going back to one other
Yeah.
than core year.
They're like, do you want to be
I will
an
not.
anesthesiologist? I'm like,
No.
not really.
this is actually a great plug for our Carver College of Medicine, because we offer our first year students these incredible career advising opportunities, and you get to connect and interact with physicians from all different specialties, including the ones we're speaking about: neurosurgery, orthopedic surgery,
ENT.
anesthesiology,
Yep.
ENT, and all of those happen in your first semester of medical school.
I've been here
Which is incredible.
3 months, and I get to go chat with the neurosurgeon.
Figure it out. Figure out what you want to do.
I do remember
Come on.
I went to the neurosurgeon one, not because I was interested in being a neurosurgeon, but just because I wanted to see what it was like.
They're crazy.
And I was
Yes.
throttled the whole time. I
Yeah.
was like, this is crazy.
I work
When they were because part of the like networking things, like they give a little presentation and then they talk about kind of their day to day as a neurosurgeon or whatever specialty we're talking with. And every single one of them was like an 8th year resident.
Yeah.
and they were all like, spoke very positively. And I mean, it sounds like an incredible like community that they've built.
That's because they don't talk or see anybody else.
I know. And it really,
You're
I
in
was.
residency for a minimum of 7 years.
Yeah, I was sitting there and I was envious of like just how much camaraderie they clearly shared with one another, standing up there because they worked on the same team. But they were all saying the same thing. We're like, you have to be willing to sacrifice time with your family, time with your friends. You need to essentially live in the hospital if you want to do this. And like, they clearly loved it. And I was envious of that. Like, it seemed like they really loved their job. But I was just like, I could never, that's not what would make me happy.
So you're
Or
saying
Stockholm syndrome.
We're saying neurosurgery is like Grey's Anatomy.
Yeah, no.
Basically.
I was talking to she's a 4th year resident that I was working with I led like the M1s MSG small groups, and they do 2 years of research, so she's in her research years right now, so that's why she's a little bit more flexible. But she's like, she isn't from Iowa, and she did not go home for 3 years or see her family in person for 3 years straight. She's like, I think I called them twice in her first year of residency. So she talked to her family 2 times in the entire year. And she was like, I didn't even know that had been a year. Like, I didn't. Like, I got 5 hours of sleep a night and I was at the hospital all day. Like, what do you do? I'm like, we're different people.
Sounds great.
Yeah, and that's like, I don't know. It's residency. I think resident physicians and what they expect of them is just unsafe, right? Like, pilots have duty time. You cannot be, unless you get like a special waiver from the FAA. I actually don't know if that part's true, but you cannot be on longer than 14 hours. Pilots will strand crews. They will just say bye and pick up the helicopter and go home because they cannot fly.
I've had it happen.
Past a certain time, right? And it's a very real thing. But residents are expected to be on for 24 hours or even longer in some cases and be able to be functional during that entire period. The concept of a 24 is nuts.
At the end of our 3-hour exam, that I guess it only took me 2 hours, but I was non-functional by the end.
Snaps to that.
What do you mean? You were done before that.
I will not speak to that. No comment. I also it was interesting because there was like a surgery like interest group meeting, and I fully only went for the food because they had La Reina, and I was like, I really want those
That's so fair.
tacos, but not interested in surgery. But it was interesting to like listen to them and everything. But there was like a plastics surgeon, and he was so funny because he was older, where he was like, back in my day, it was before they put in those requirements of 80-hour week, and he would do like 120, I think it was, or 140.
Yeah.
It was like something crazy hour week.
How
Like
many
it was like
hours are in a week?
I did the math.
Not
times
not
more
that
than
many.
140,
Not
I
enough
guess.
to be doing.
What is
120.
it? What is
7 times 24.
Yeah, that would be 168, and he was doing pulling. I think
Oh
it was
my
like
God.
140 was what he said or something. So like that's how much sleep he
Yeah.
got was outside of that, and he was like,
I
yeah,
would
it was
pass away.
Yes, yeah.
And then Isaac would. That's my husband's name. He would also pass away because he'd be like, "Where is she?"
Yes, and also
I want to have a dog in residence.
Palliative
Yeah.
care for residents. With
Yeah, right.
And it's just it was insane, and it was just him being like, yeah, it probably was like unsafe for my patients, and I'm like, yeah, and you're probably gonna have like dementia because
gonna
like
say.
your poor brain
The
is
lymphatic
like,
system is not going to be working.
yeah. So anyways, I think that and there's this thing about like, well, we were like tough enough to do that, and it's like just because you can do something doesn't mean you should.
It's like the old like a 90s football coach being like, you don't get a water break, that's for the weak. And then we find out now, like doing like exercise science research, that's like, that's super bad for you. They will perform worse without water.
yeah.
Like, don't do that.
I knew there was a reason my team just kept getting
Yeah.
worse. No matter our coach.
And
got-
that was the entire reason.
Yep, that was.
It's just the
definitely-
water. You were all just dehydrated.
Definitely not me. Yep.
Volume depleted.
Yeah,
not
volume
dehydrated.
depleted. Oh,
Honestly, probably be hypernatremic though
Yeah.
if they're losing all the water.
I don't want to
Probably.
think about it.
What is
you
ADH
know?
doing? What is the
It's
the
gotta
RAS
be
system
ADH
active?
dependent, right?
What is your fractional
I don't
We
know.
just
We
had an
haven't done
exam.
kidneys yet. I don't
we
know.
just had an exam on the
I'm
kidneys.
with you.
I'm so sorry.
What even is a kidney? It's like
Yeah,
it's a thing.
I'm gonna.
Ideally,
We had a friend yesterday that said she was gonna take out both of them because
She's
she's
like,
tired.
I'm so mad at the kidneys. I want them both removed. Stat.
I have a friend who, until they got into the anatomy dissection lab and opened up a kidney, they thought the whole kidney was just one nephron.
Oh.
You know,
Like-
actually, that's fair. That's fair. I get it.
That friend was you, Sarah.
Yeah,
I mean,
no.
I feel like before I first took anatomy, it was just a bean. You know?
Yeah,
Like,
right.
that's
Oh yeah,
all
I thought of it as
it
a bean,
is.
but I was like, there's
Like,
stuff
I
in
can
there.
tell
There's stuff in there.
my husband stuff about an organ, and he'll be like, I know I have that organ. And it's just like, it's just such a contrast of like how, like even the conversation we're having today, the contrast between like what people outside of medicine, like what is considered common knowledge and what their
Yeah.
conversations look like versus like people in medicine and people in medical school where we're just like, we just joked about ADH. Like, think
Yeah,
about
that's
that.
not a general. That's not a general population joke there.
And we like we
Really?
use so many acronyms all the time. Like you
Yeah.
shouldn't be able to have an entire conversation in acronyms.
also the things that excite us.
Yeah.
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 They stopped lecture 3 minutes early. I get 3 extra minutes for lunch.
It's all relative, man.
Or it's like
Yeah,
on our
I get, like, so
last
excited.
exam, I heard like the murmur that I knew what it was.
Oh,
I was
yeah.
like, yes, this is amazing.
I got really excited because we got to interview real patients for the first time at the
Oh, yeah.
hospital, and I
Wow.
felt like a big girl. And then there was one of the other student groups had interviewed a guy that had a mitral regurgitation murmur, and then I was like, "Can I please go listen to it? Like, do you think he'd let me?" And he ended up being taken to go get a scan or something, but. I was like, man, I didn't get to listen to this murmur. It's my dream.
Shortcoats, if you have something you want to say about today's show or something you want to hear about someday, a question you have, go to theshortcoat.com/tell us and send us a message. Otherwise, that's our show. Until next time, I'm Dave Etler saying, don't let the bastards get you down. Say bye, everybody.
Bye. Bye.